Welcome everyone to this very special Hope Zoom presentation this Wednesday, April 3rd. And I would like to introduce Dr. James Pingpank, who really needs no introduction. Dr. Pingpank is an esteemed specialist that has he's with UPMC, University of Pittsburgh Medical Center, and it has been working with PMP patients for decades. And, he's a published author, speaker, and just really a long time friend of pals. When our founder, Gabriella, was alive, Dr. Pingpank, connected with Gabriella. And, we're just grateful to have him here today and appreciate his support and the comments that he'll be making about the role of a patient, which is something we're all interested in. Okay, well, Dr. Pingpank, I will turn it over to you and just let me know as you want me to advance the slides.
First of all, very happy to be here. This is a great organization. We appreciate their support along the way for literally decades. I have no disclosures. We don't get any funding from any industry with regard to any of the things I'm going to talk about today. I thought it would be helpful just to sort of go back to some of the basics and talk about the way we look at things, but also give this in a context of especially for newly diagnosed patients or patients who are undergoing transitions in their care, sort of how to think about things. And people always ask us, what should I be asking, or how should I be running my care? And I thought these were some good things to go over. Some of them may be basic for people who have been going through this for a long time, but with things changing also, I thought a little review would be helpful. So first, just to go over some very basic cancer terms, which I use this slide a lot whenever we're teaching. One, obviously, is to talk about chemotherapy, but it's not just the chemotherapy, which is any agent which can help us kill or keep from growing any tumor cells, but also the fact that drugs can be administered a variety of different ways, including intravenously, which is the standard way of giving it, but also either through a HIPEC or a peritoneal perfusion, or it can be delivered through a catheter into the peritoneal cavity, what we call IP, or intraperitoneal chemotherapy. Really not yet all that applicable, but maybe down the line is the use of immunotherapy for especially low-grade malignancies or low-grade tumors with PMP. And with ovarian and some sorts of colon cancers, you are starting to see that more and more, and probably mesothelioma will see that more and more. But there's really two types of immunotherapy. We have one which is just a global immunotherapy, which helps decrease the body's brakes on the immune system. But more interesting for us is the use of what we call specific immunotherapies, which is the ability to grow up cells from patients' tumors and give them back to patients and see if they can help the body fight off tumors using the immune system. And this is something that we and several other groups have been doing, especially with the higher grade cancers. In general, people ask a lot about radiation therapy. Radiation is very similar to surgery in that it is a local phenomenon, meaning it doesn't do anything outside of the area where you treat. But especially with things like PMP, where long-term survivorship is expected in a lot of cases, the use of radiation can give you a lot of side effects that make it difficult to use other therapies. And so we really don't have a role for radiation with the vast majority of patients with this disease, and really shy away from it as much as possible. One of the other things that I always like to stress is when people ask for staging, and we'll talk about this a little later with PMP, but in general, we stage people by pathology, looking at the slides and what we see in the operating room, but also by imaging. And those two areas can be very different, but ultimately it is a pathologist who rules the day. And we're looking at what does the primary tumor look like under the microscope and how deep does it invade, but also looking at regional lymph nodes and the presence of metastatic disease. And we'll talk a little later about that, why PMP is a little different than other diseases, because it's not always when we see the side effects of PMP, it's not always associated with tumor cells being outside the abdomen, and that's a pretty important concept. So specific PMP terms. One is the use of the phrase pseudomyxoma peritonei. That is really designed to talk about the mucin or the contents that are released from the tumor cells into the peritoneal cavity. I think it's always very important for patients to know it's pseudomyxoma peritonei from whatever low-grade mucinous tumor, higher-grade mucinous tumor, ovarian cancer, colon cancer. So it's not only the PMP, it's where the original tumor arose from and how it looked under the microscope, and that's extraordinarily important. Peritoneal carcinomatosis is another thing that people use interchangeably, but really it's very different. Peritoneal carcinomatosis is really the spread of metastatic cancer cells into the peritoneal cavity, and that can be either from an organ that arises in the peritoneal cavity, like the colon or the stomach or the appendix, or it can be systemically from breast or lung or other organs, where it's a very different problem when it comes from an area outside the abdomen. Cytoreductive surgery, which we all talk about a lot, is the ability to go in through an incision or sometimes laparoscopically and remove all of the visible and palpable tumors that are in somebody and do our best to preserve as many organs as possible. Intraperitoneal chemotherapy is the administration of drug into the abdominal cavity just as a way of putting it in through a catheter, very similar to what an IV would look at like. And hyperthermic intraperitoneal chemotherapy, or HIPEC, which is what most people end up getting, is a recirculation of a very high dose of chemotherapy into the belly with heat over time. So that's a little more of a complicated intraoperative administration of drug. And then I would just say, when people talk a little bit about imaging, and I'll talk about this later when we go over a specific question, but the use of imaging and staging is that the MRI and CT scan, although they overlap a lot, sometimes there are differences in them. And so in general, we try to use MRI once a year to get a much better view of the peritoneal cavity. But that's not always possible at all institutions, mostly because the machine can be very fussy between institutions. And so what works at one place won't work at the other, not because of skill or competence, but because of the nature of the machine that each institution has. So we only do it at about 4 of our 20-something hospitals, just because the machines are so different. At time of initial diagnosis, the things that we think are really important is, one, getting a diagnosis, like I said, so knowing where the primary tumor arises from and getting that histology. And really, as people come to see us, we always request that we see the slides so that one of our pathologists can review them, so that we're all using the same terminology and it's the same people having the same conversation for each patient. Stage is important, looking at lymph nodes, looking at metastases, and I'll go over this a little more in detail again in a minute, but really looking at what is going on in the peritoneal cavity. Are we just seeing mucin, or are we seeing tumor cells? And that's a very important thing. And if people have had an appendectomy, sometimes there are lymph nodes in the specimen, and sometimes there aren't. But really, the desire to get lymph nodes is based upon how the appendix looks under the microscope. And then these things you should sort of leave your doctor's office with, knowing those things, but also really leave with, and it may not be the first time, there may need to be other information gathered, but before anything starts, you should have the diagnosis so that you know exactly what the tumor type is. You should know the stage of it, and then there should be a very clear-cut therapeutic plan. Now, sometimes that plan won't be possible until a diagnostic laparoscopy is done. But really, you know, the therapeutic plan based upon imaging and whether or not you're going to have a surgical therapy or, you know, chemotherapy first plan is something you should be able to sort of have that long-term plan. And sometimes that's when people get sent off to institutions like ours that have a little more experience, so that that plan can be at least laid out. It doesn't need to all be done at our place, but usually a lot of it is. Really, in this group of people, radiation oncology is there, but is very rarely used. But when you talk about a disease that is this complicated and relatively rare, and really can be quite different in the way that it presents person to person, the four people who you see outside the radiation oncologists on this list are really important components of care. And before anything starts, all these people should be involved. For us, the pathologist is the most important person in the room, to be quite honest, because they're the one who are going to look at everything and really tell us, has this tumor ruptured? Sometimes it's just the appendix that's ruptured, not the tumor. What is the grade? What is the cellularity? All those things are very, very important. So we have a very tight group of pathologists who review things. Medical oncology and surgical oncology should see everybody, because the discussion of chemotherapy is always relevant as our surgical planning as to what can be done and what should be done. You'll hear several times is, having a nutritionist on board in these chronic diseases, but also these diseases which can present late because of their insidious nature of starting. Really having very good nutrition and with a nutritionist is a key part of every team. So really, the role of friends and family, this is something that actually the first time I heard this talked about was, I think, at one of the PMP symposium many, many years ago when I was still at the NIH. And I think it's really important to have people with you sort of consistently. And it doesn't need to be everyone in your family, but find that one or two people who are always, or the majority of the time, going to be with you, because people like to record when we talk to them. I'm not a big fan of that, because I don't mind if they do it, but what I tell them is, if you're recording me, you have to make sure that you're also sort of working through the process at the same time, because I worry that when people record, they say, well, I'm just going to go back and understand that later, rather than sort of really getting everything teased out while we're having that conversation. And that's where having a friend there or a family member who can take notes and you've gone over things beforehand, so can remind you of the things that you were concerned about. A big thing with this disease is, where do you get treated? There are a lot of great centers around the country, but obviously not everyone lives near one. In general, I think most of the centers do a very good job of coordinating with local centers so that people can get significant components of their therapy at both places and have it done relatively seamlessly. And then I think the important thing also with regard to family and friends is having someone who's going to be with you through the process of survivorship and recovery, and the process along the way of follow-up. It can be daunting at times, and it always takes a little longer than people think. So having someone who's there, who knows what to expect, can push you a little bit, can help you a little bit, can get you through the rough times. So having that sort of group of people when possible, and certainly groups like PMP Pals are very helpful too, but really having someone walk the walk with you is very important. Patient factors that affect overall performance and overall outcomes are very important with this disease. This is a disease that people do very well in general for a long period of time. And so I think we have to be very aggressive at addressing these health problems along the way, because if we don't, they're just going to get worse. And as more therapies are needed or more interventions are needed, they become more of a problem. So smoking and exercise are things you can address right away. And we should address right away to optimize people's ability to tolerate therapy. Nutrition and BMI or obesity are things that we really need to talk about, because some people come in and they have had symptoms that are sort of insidious by the time they're diagnosed. And although they feel like they're bloated and gaining weight, if you look at the amount of fat in their body, it's actually quite low. And so in those cases, really spending 2 to 3 weeks to tune up the patient's nutrition before anything happens is really important, because it's going to improve their outcomes. And part of that is going to be exercise while they're doing that to get stronger, but also really to have a good, healthy, high protein diet. And then it's also a disease that if someone comes in with some active cardiac disease, almost always we have the ability to intervene and get that cardiac disease treated first, even if it requires a stent or something, in order to get someone who's going to actively tolerate a therapy much better. So again, PMP, pseudoxanthoma peritonei, is clinically, and this is one of the few slides that has some medical pictures on it, is characterized by the presence of mucinous ascites. So ascites is just fluid in the belly that's outside of the intestine that doesn't belong there. It happens because of irritation. And so this is much more of a mucin or a thicker ascites than we see with people who have like cirrhosis or something else. You can also see nodules of tumor there. This almost exclusively arises from ruptured appendiceal mucinous neoplasms. And this is what the belly can look like, with the grayish areas being abnormal areas of accumulation of mucin that you usually don't see. And there's really three types of appendiceal progression or stages along the progression. One, this is just a dilated appendix, which shows no evidence of perforation. And here the pathologist would tell us what's going on. The second slide is a tumor or appendix that is perforated, and that's the mucinous or mucus-like ascites that's coming out of the bottom. And then this is someone who has much more extensive disease throughout the peritoneal cavity, someone whose tumors have been ruptured for a long time. In the second two pictures, the most important thing is going to be, what is that fluid? What does that material look like under the microscope? Sometimes that's all mucin, meaning we don't see any cancer cells. And sometimes when we look in there, there's a high percentage of cancer cells, and that very much dictates what the nature of the therapy is going to be. So this is, I think these slides are all going to be available. So, but the most important thing is just the column all the way on the left side of the screen. These are the terms you will hear a lot. One is an adenoma, which is just a benign tissue growth. So dysplastic does not mean malignant. But an adenoma is a benign tissue growth within the appendix that, if probably not removed in a decent amount of patients, would become a cancer, but is not. And so there's nothing we need to do about it. The low-grade mucinous tumors of the appendix are what the majority of people with PMP have. And it really depends upon how they look under the microscope, but more importantly, how they're presenting clinically as to what gets done. But if that's all you see, then in the appendix, then these are ones that people do very well with. The higher grade tumors are ones that have very similar mucin type production, but when the pathologist looks at the cells under the microscope, they see more aggressive looking cells. And I know there's a question about this later, and we'll talk about it at the end, what the difference is between the two of them. But usually there's also not a crystal clear delineation of it's one or the other, and frequently we'll see mixed type tumors. And in those situations, then when that happens, we very much use what the predominant cell type is to decide how to make therapies. And then if you see one where there's actually a tumor that's invaded the lining of the intestine, not just perforated with the mucin, but actually invaded the lining, that's when we have an adenocarcinoma. And those are much more aggressive tumors. Those are ones which tend to go to lymph nodes, and ones where we tend to want to use chemotherapy as part of the care. So not only do we look at the primary tumor, but like I said, we look at what's going on in the mucin. And often that's much more detailed and gives you a lot more information. So if you even have a high grade or a Hammond and you look at things and then you don't see anything in the mucin with regard to cells, then we know that there's been no spread, even though there's been some mucin which has leaked out. But if we see evidence of more aggressive looking cells under the microscope within the mucin, then it does dictate sort of changes in therapy that we may need to see. But in general, the low and the grade 1 and the grade 2 tumors are ones that respond very well to regional therapy. It's only the patients who have the higher grade or the signet cell rings where we predominantly rely on IV chemotherapy. So how do we treat people? So if the tumor is unruptured or the appendix is unruptured, and it's a mucinous tumor, either a low-grade Lyman or a high-grade Hammond, appendectomy alone is plenty to treat the patient. If it's a mucinous adenocarcinoma, these are ones where the ability to look at lymph nodes are very important, and those are patients who will get a right hemicolectomy so we can have plenty of lymph nodes to make a decision on chemotherapy. In patients who are ruptured, either a little or a lot, the decisions are based upon how does the mucin look. So if we give the pathologist a ton of pathology to look at and they see nothing but mucin, then that's not something that we worry about that much. There are patients who may need multiple procedures over their lifetime, but in general, they do very well with clearing just the mucin out of them and whatever needs to be done to do that. When we look at the grade 1 tumors, then those are ones where we are a little more aggressive and they'll need an appendectomy or potentially a colon resection in that area, and also get a cytoreductive surgery in HIPEC. If you just have pure acellular mucin, the use of whether or not you need the HIPEC with the cytoreductive surgery is a little bit controversial at this point. But if you have grade 2 or grade 3 tumors, so more aggressive, those are patients who, A, you want to be able to make sure you remove absolutely everything in order to justify a surgical intervention, and ones who also get systemic chemotherapy either preoperatively or postoperatively as part of their care. What we see in this is, if you look at it, if the overall survival, which are the graphs on the left, you can see that the blue line, which is low-grade tumors or lamins, those patients do very well, even with very extensive disease over extended period of time. And this is, 120 months, so 10 years out. But as the tumors get more aggressive, the red or the green to intermediate grade, which is grade 2 or grade 3 in the green, those patients get more aggressive tumors, and so survivals are decreased. But in general, the majority of patients do very well, and even with intermediate grade tumors, median survivals are over 5 years. That's it for that. I'd like to answer a few questions, and we have a few already which have been given to us. I think the one which I touched upon a little bit is what to do with tumors that have high-grade mucinous neoplasm as a focus in a lower-grade tumor. In general, we tend to treat those patients as a lower-grade tumor based upon the percentage of what's high and low, but there's certainly patients who undergo an aggressive cytoreductive surgery and they get HIPEC at the same time. We use mitomycin C for 100 minutes. And then what we end up doing is giving the pathologist a lot of tissue to work with. And so then they'll have a definitive diagnosis as to what to do. And if it's only a couple scattered cells that look a little higher grade, it doesn't change anything. If it's more than that, it just makes our follow-up a little more frequent. And we're going to watch a little more on shorter intervals, but essentially every 3 months for a couple of years, and then goes ahead and we'll go and start with systemic chemotherapy. We'll avoid systemic unless we see anything that looks like it's invasive. But in general, most of those that have just a little bit of high grade end up being treated as the lower grade. Other questions which I get, and then actually this first one has to do with scans, and it's something that we get a lot of, that a CAT scan did not pick up on the tumor. And so how can we feel comfortable following people with a CAT scan and follow-up? That's a great question. The reality of it is that there's no perfect scan for this, but that's why we do use MRIs at least once a year. And a lot of centers do that now because they are a little more sensitive for things. But the reality is we never can tell someone they're cancer-free. We can just tell them we don't see any evidence of disease, and we
do MRIs once a year.
We do MRIs once a year. And if women are worried about fertility and everything else, we can do it more often than that. But I don't think they need to be done any more often than that if you're getting high-quality CTs. But I generally tend to use MRIs once a year. They're much harder to do, and they're much more resource intensive. And so even at a high volume place like us, we can't necessarily get every patient an MRI every 3 months in the first year post-op because there's just not enough time on the machines to do that. But we tend to get one pre-op and then get one once a year for follow-up. And if the CT and the MRI are negative, we never tell anyone they're cured. What we tell them is we don't see any active disease. We're in a really good spot, and that's a sign of very, very good disease control, and we'll just keep following them. But certainly there will, I've had patients go 10 years with negative scans and all of a sudden have something pop up on an MRI. That's caught very early. It's something we can intervene on in a very straightforward manner. What besides chemotherapy can I be doing to improve my situation? I think that most importantly, your global health is very important. Nutrition, activity are really important. Like I said, not smoking. But the role of chemo in this disease is really based upon what the primary tumor looks like. And so if it's a low-grade tumor or there's not a lot of cellularity, we try not to keep people on chemotherapy forever and ever, but follow tumor markers and give people breaks along the way. Certainly with something like Xeloda, which is an oral 5FU, we can keep people on therapy off and on for a very long time and keep the disease under control. But I think that it's really important for people to stay active and stay healthy, so that when things do need to be done, their health is in very good shape. As far as patient advocacy, when are you pushing too far and when are you not? I don't really have a good answer for that, other than to say that it's really important. I think for diseases like this, telemedicine has been a really good thing, because you're going to hear different things from different people, and often you're hearing the same thing just said differently, but one person may say it better or a way that resonates with you, or just the second or third time you hear it. But asking questions, and most importantly, really listening to, that's why I think having a friend or somebody really listening to what people are saying is important, and making sure that you are comfortable that you have all the information you need. It's very rare that any of these things are surgical emergencies, and so I think it's important to be evaluated, get an opinion. If you have to get a second opinion, get a second opinion. They're always helpful in my mind. And then just take a time to talk about it with your primary physician, and really make sure that you understand what's going on. And frequently that's the physician will trigger other questions, or this isn't being answered, and we'll tell people if there are unknowns, especially in people who have had appendectomies and had cancers develop. There's always going to be unknowns, and people get very anxious about that. But the reality of it is, there's a little bit of time and then a repeat exam are probably going to be the most beneficial things. But you should really walk out of every appointment knowing, this is where I am, this is what the plan is, this is what we're going to be looking at and looking for at the next evaluation. My thought on supplements are that most of them are a waste of money. Most of them are given to you at such high doses that you either pee or poop them out. The ones that are sort of supplemental protein or a little bit extra vitamins are great, but whatever you can get through natural diet is the best. Anything that's super expensive is just a waste of your money. But some of the more grain-based supplements, higher protein supplements, all the things that are just sort of trying to make sure you don't have any little holes in your diet, as opposed to mega this, mega that. All those things that are, sort of high-end multivitamins can't hurt. And so as long as they're not super expensive, there's not a problem. There's nothing that interferes with your therapy, and there's nothing that causes toxicity or causes cancer. That's important. You cannot starve a cancer at the expense of your own body. So your nutrition, if you have a tumor that's taking your nutrition, no matter how hard you try and trick it, all it's going to do is keep taking things from your body. So a good, healthy diet is the best way to keep your body strong and sort of make it through the battle. So we get a CA99, and a CA125 on everybody at diagnosis. And then, unless they're on a specific clinical trial, we just follow the ones that are relevant. And that can be any of them, all of them, or none of them. And so we just follow what's relevant. The MRI machine question. So can I advise which MRI machine is required? No. It's not that you can't do these on any MRI. It's that the protocol is very, if Philips changes a version, it can all of a sudden we can't use it with the protocol, and someone has to rewrite the protocol. And that's a trial and error. So that's why it's only used at a limited number of spots, because it's just a lot of trial and error back and forth. And so it's places that have put the time into doing it, do it. And then so that's really just a question of the comfort of the system doing it, and having enough volume to do it, and having the technicians who can handle it. When UCSD is actually the first group to do it in San Diego. And when we saw the results, they were fantastic, and took us 9 to 12 months just to get it to where we could replicate their work on our machines, because there were minor differences in the machines. So it can get fussy. And, places that do a lot of breast have a different MRI than places that do a lot of prostate. And so the right machine just may not be in specific institutions. That's not a value judgment. That's just sort of based upon what people do.
I think maybe the next question, what things do you see with the MRI that you might not see in the CT?
You can see the lining of the intestine and the lining of the peritoneum just a little better with certain contrast techniques. And so it can show, and so it's just you can use contrast in a different way with the MRI than you can with the CT scan in order to see that. It is especially helpful in patients who you're trying to plan surgery for, who may have some subtleties in different areas, and we found it to be very helpful in patients with low volume disease or patients who we're going to follow without an operation. But like I said, the majority of our patients do just get followed with CAT scans for the majority of their follow-up and get only MRIs once a year.
Have there ever been any cases where patients have survived without chemo or surgery?
I'm not sure what you mean by that. Usually you have to have a surgery. So if people just have their appendix taken out and there's mucin and a little bit of low volume mucin, then like if they come to us and someone says, well, we did an appendectomy and there was a small amount of mucin, but nothing really bad, and we get imaging and it's negative, we won't go back in those patients and we will follow them over time. And so there are some patients with very low volume disease. There are certainly some patients who are not surgical candidates who don't have that high a volume disease, and we will follow them on their imaging, especially if their appendix or their primary tumor is out. And as long as tumor markers stay stable and imaging stays stable, I think they're in the comorbidities make them a high risk candidate. I think that works well. But in general, most patients, the overwhelming majority of patients, need some sort of an intervention.
When adhesions develop after CRS and HIPEC, how long do you recommend waiting before surgical adhesiolysis? Not sure I'm saying that correctly.
Yeah, adhesiolysis. It really depends on the patient's symptoms, and that's our experience is the adhesions are not any worse after HIPEC than they are after any major surgery, and the side effects of them. A lot of it depends on the volume of tumor that was there. A lot of it depends on sort of what was done. But if a patient has, one admission a year for symptoms, we tend to not do anything because every time you go back in to operate, you create more adhesions. But in general, that's, the decision-making point is based upon how symptomatic patients are and how quickly they get back to good, GI health when they have these episodes. We try not to go back into people. It just, after any major surgery, a significant amount of adhesions, if you have to take them down, the risk is that this is going to recur. And so unless someone is having, multiple episodes or really prolonged episodes, we try and avoid a surgical intervention.
After treatment, how long do you recommend surveillance? Once a year, the rest of your life, 10 years, 5 years, something else?
So our program is once every 3 months for the first year, every 4 months for the next couple of years, every 6 months until year 5, and then yearly until year 10. I have multiple patients at year 10 who have said, I still don't feel comfortable doing nothing, and so we'll continue to surveil them every year or two. But that's the way we go.
With regard to your presentation, there was a question regarding goblet cell adenocarcinoma and not seeing it on your list, or if you could explain where it falls on your list.
Very, very, very different group of tumors, much more along the lines of the adenocarcinomas. And so pathology really drives everything. But in general, you're looking for high, intermediate, and low grades. And systemic chemotherapy is much more likely to be relevant in those patients, but it's really a very different group of patients. Don't tend to present with as much pseudomyxoma as much as peritoneal carcinomatosis or cancer cells within the peritoneal cavity. So in general, a more aggressive phenotype, and one where when we talk about surgical intervention, we need to make sure that we can absolutely get everything out. But another one where is if the appendix comes out, you have a goblet cell carcinoid in the appendix, no matter what the grade is, and there's no spread anywhere else, then you're probably looking at just getting a right hemicolectomy in order to look at lymph nodes, so you can make sure you're adequately staged. But those are ones where when we start to get peritoneal disease, the prognosis is more difficult, and the therapies have to be a little bit more reliant upon systemic therapy, meaning intravenous chemo.
And you may have addressed some of this, but staying on goblet cell, can you talk about improving outcomes for patients with goblet cell after treatment?
It's a hard thing to pin down unless you know specifically sort of what subtype. But right now they are a more resistant tumor to chemotherapy. They're more resistant to surgery. And so we tend to lean very aggressively on intravenous chemotherapy as a component of the therapy of the patients.
If after 10 years of clear scans, as you mentioned, what would be the first intervention if you see a recurrence of localized lamin?
Depends on the volume and the location and how it's picked up. I mean, occasionally, I guess someone's first presentation could be symptomatic, but if we see something very soft and very subtle, our usual plan is to follow up imaging in 4 to 6 months. Make sure the patients have their colonoscopy, but really make sure that A, it's not sort of some idiosyncratic thing, and B, if it's really small and just sort of became, I mean, you think about it, that's been there since day one. And so if it's just gotten big enough to see over 10 years, depending on the patient's age and what's going on and everything else, it's something they may not want to do anything for a while, just so we can see how it's going to progress, especially if it's not going to cause a problem. If it's in an area like next to a ureter or something like that, where it could become problematic if it grew too much, those may be patients where we'd intervene a little earlier rather than later. But in general, if something takes that long to come back, then we tend to really make sure we've assessed where we are before we jump back in and do something.
All right, this next comment is from a patient of yours who says you are his hero. He surgery was 7 years ago and has CT scans every 6 months. But again, how does he know that there is mucin growing, and what would be the intervention if that's the case?
So we don't know that there's not, but 7 years out, we have a very good sense that whatever is in there is minuscule. And so with not seeing anything on CT scan and seeing normal tumor markers, we just watch and wait. But the intervention would be based upon what we see. And frequently, if we see something very, very small, we just watch and wait. And if we see something that's bigger or it's even not that big, but certainly changing in nature, then that would be something we'd intervene on right away. But it depends on what it looks like on the scan. If it's just a very small pocket of mucin, a lot of those will come back as being acellular. And so a big operation to get those out is just the definition of a long run for a short slide. So we would watch and wait on that. Redo operations have larger incidence of bowel resections on them. And so we want to make sure that if we put someone through that we make sure that it's something that's that what we're taking out is something that would affect the quality or length of their life.
The next question, if a patient was stage T4A, can acellular mucin create seeding mucin and nodules in the pelvis? Or is it more likely some of the epithelial cells were missed, given the lamin having scant cells and the large peritoneal surface to biopsy, et cetera?
This is what keeps us up at night. This is why we get follow-up imaging after someone has had an appendectomy. So someone who presents with T4 disease and is perforated, and the sites that they took out did not have any cells in, but only had mucin. We let them recover from their surgery, and then we'd have our pathologist look at their pathology. We check their tumor markers, assuming all that's in agreement. We'd repeat the scan in 3 months. If we didn't see anything, we just continue to follow the scans. If we see something that's suspicious, those are patients who would get a diagnostic laparoscopy to see if we see anything. But in general, if it's truly acellular mucin outside the appendix, and the perforation is not at the site of the tumor, but is the appendix perforating distal from the tumor so that all you're getting is mucin, we can honestly tell those patients that if we end up going to the operating room in a year, because that's when we finally see mucin, they're going to do just as well as if we go back in the operating room right away and do a big operation. And there's a significant number of patients who in that exact scenario who we've been following and have never needed a bigger operation. So being prudent is the smartest thing to do. All these patients get presented our tumor board. They all get reviewed by our pathologist. They all get reviewed by our radiologist. If there's any concerns, we stick a scope in them to see what's going on. But in general, if we don't see anything on any of the imaging and our pathologist tells us there's no cancer cells, no epithelial cells outside the appendix, you should feel very comfortable watching and waiting. Unnecessary operations are a bad thing.
The next question asks, which chemo, FOLFOX or FOLFIRI?
Everybody starts, at least where we are, starts with FOLFOX if you need it for systemically, just because most of our clinical trials as second line are based upon FOLFIRI. The reality of it is that either one of them works very, very well. So we have patients who are surgeons or pianists or artists, whoever, the side effect of oxaliplatin is some neuropathy of the hands and feet. And those patients are ones that go to FOLFIRI first. But there's not, if you look at all comers, there's not a difference between the two.
Have you done many repeat CRS hypex?
Yes, it's tough, but it can be done. And if you, the main thing we use is what is the benefit of the first one? And if people get at least 1.5 to 2 years out of the first one of good disease control and good benefit, and we don't have other options, and we feel it's warranted to do the second one.
Any thoughts on repurposed antiparasitics like fenbendazole? Could this help or hurt you?
No clue. We're all looking at different agents to look at intraperitoneally, but we don't really have a source, and we don't have a good target on cells or a causal source. So it's hard to know. All the drugs that people are looking at it's hard to get large numbers of trials. So in general, we don't use those.
Will someone's CEA go up due to COVID?
Good question.
Yes.
So if it does, it should go right back down. I guess any sort of inflammation. I mean, you can get it with bad colitis, but not in any way that will go up and stay up, and not in any way that's extraordinarily high. So I haven't seen a false positive because of COVID.
Do you recommend Avastin for patients that are mid-grade and have had 2 CRS hypex?
I try and avoid Avastin as much as possible with patients with peritoneal disease. There was a trial at the NCI for ovarian, and there were a lot of fistulas for it. So in general, other agents work just as well. So we try to avoid it.
Yeah, and the question goes on that if you do use it, should you pair it with something else? Are there risks of bowel perforation, et cetera?
Significant risk of bowel perforation in general as a maintenance alone. It doesn't really work. So we try and avoid it.
Okay. Why do patients need a right hemicolectomy?
To look at lymph nodes and make sure the local control is good. So for patients who have any disease that is potentially going to go to lymph nodes, the right hemicolectomy gives us lymph nodes to look at. And that's how we decide who gets systemic therapy, based upon what's going on in the lymph nodes.
Is there value in having a repeat diagnostic pathology assessment after chemo and or surgery?
No, I mean, it doesn't. The chemo or the surgery doesn't change the way the pathology looks. So no, it is not going to. The tumors aren't going to change because of the therapy. So it's really based upon imaging.
Is there always a cell type?
There should be. So the cell type is absolutely what drives prognosis and drives therapy.
Okay. And so with a mucinous adenocarcinoma moderately differentiated, what would that cell type be?
So that is something we'd have to. I don't want to answer that without looking at the report, because it's hard to know where that's coming from. But in general, that's a true invasive malignancy, not a Lamin or a Hammond, and those are patients who would need a right hemicolectomy and systemic chemo. But sometimes the terminology that comes out of places is not the terminology we use. So they may be talking about something that's truly not an invasive cancer. Okay. So that's where pathology review and second opinion is very, very important.
Could you speak to the difference between Lonsurf versus Zolida?
That's going to have to be a medical oncology question. Sorry.
Okay. What is recommended for the second and third line of chemo?
Well, so we go basically off of colorectal regimens, and so we start with FOLFOX as our front line. Second line is FOLFIRI, and then third line is usually clinical trial as far as a therapy.
Any value in having a Frontier 1 genetic assessment?
We do the genetic assessment on everybody. Right now, everything is really based upon just upfront systemic chemo.
What are some advances on the horizon, or what are some things that
The biggest thing we're going to see is the use of mucolytic therapies, or therapies designed to, disrupt mucin production in patients who are unresectable. I think that's the next best thing. But other than that, it's really going to be just better delineation of who needs therapy and who doesn't, based upon really good imaging and staging.
Okay, well, thank you so much, Dr. Pingpank. I mean, this was wonderful. I mean, we appreciate your insights and sharing your knowledge with us. And and if we have a few stray questions, I might just send those your way, and we'll
Yeah,
get answers to the individuals. But we can't thank you enough for joining us today.
My pleasure. Thank you very much. Bye-bye.
I know. And for those of you that joined us, thank you so much. If you do have follow-up questions, please send them our way, and we will get those to Dr. Pingpank. But we hope this was valuable for you. I think every time we have a presentation, it gives us new insights and helps us understand dealing with this disease. Please, again, stay in touch with us. Those of you that are new, please stay in touch. Those of you that are not as new, please keep coming back. But I hope you all have a wonderful evening.